Ladies and gentlemen, our next presenter is from Brazil, and no, he doesn't have any spare tickets for the World Cup. Dr. Estevam Bonfante from Sao Paulo is a researcher of outstanding ability. He is here to give you the basis for a lot of the things that you've heard from Vin Morgan. He's Ph.D., he comes from a dental family with father, mother, sister, and Uncle Tom Cobley and all, and I would like him to approach the podium. Dr. Bonfante.
Thank you. Well, good morning. It's a great honor to be here. I come from the University of São Paulo in Bauru, Brazil, where I teach at the Department of Prosthodontics. And as you may notice from the slide, it says Estevam Bonfante et al., so I do not speak for myself. I speak on behalf of a large group which I'm very proud to work for. And why lecture on comparative properties of dental restorations in an implant meeting? Well, because it's important to understand the clinical outcomes for tooth-supported reconstructions in order to gain knowledge on implant-supported prosthesis. And in addition to acknowledging the differences between the type of support, we must also distinguish where the prosthesis will be located. Is it an anterior or is it a posterior prosthesis? And what type is it? Is it a crown? Is it a fixed partial denture? Or is it a full arch? And lastly, and extremely important, as we shall see today, the material used to fabricate the prosthesis. And this is especially important in the all-ceramic world. So just to give you an example, this is the mechanical failure rates of a variety of all-ceramic materials, and we're just generically speaking about them. We see that the mechanical failure rates, they increase towards the posterior region. So it is in the average of 3% in the incisor region, 7% in the bicuspid, and 21% in the molar region. So there's a clear increase in problems as we go towards the posterior region. So are we going to concentrate on the aesthetic zone or on the bicuspid region? No, definitely not, because that's not where the problems are. So just to give you an example of the combination of tooth-supported crowns and the clinical outcomes with different materials, and let's say metal ceramic and all ceramic, and why are we speaking about metal ceramics here? Because we have to acknowledge that they are our gold standard. They've been in use this year for 52 years. So let us see what is the clinical outcomes according to this systematic review. In the anterior region, we see that if we use a metal ceramic or any given all ceramic material, the performance should be okay within 5 years. But when we go to the posterior region, there's a clear difference. And we see that only the behavior of reinforced glass ceramics and those of densely sintered alumina can be comparable to those of metal ceramics, okay, in terms of clinical outcomes and survival rates. And does that include zirconia? No, it doesn't, okay? And remember, we're on tooth-supported reconstructions. So now let's go to the zirconia. It's an extremely important material. We know that of all the all-ceramic materials, it's the strongest one. And here are the outcomes for implant-supported crowns, and this is pretty much all that is out there in terms of clinical studies. So we see a study from 2012, a follow-up period of 2 years. Here's the outcomes in terms of porcelain chipping. 24.5% for zirconia, 9.5% for metal ceramics. Another study from the same year on a longer follow-up, 3 years, 4% of porcelain chipping in zirconia, none for metal ceramic. Another one, 6 months, 7.5% for zirconia, porcelain chipping. Now, this is the longest one that we have. Has just recently been published in the Clinical Implant Dentistry and Related Research Journal. The 5 years follow-up, it shows a 42.8% of porcelain chipping. So what I want to highlight here is not really how unhappy the patient will be with a fractured crown that has just been recently installed, but most importantly is the huge variability that we have in clinical outcomes. And I bet you may wonder that this is due to the use of different zirconia systems. And believe it or not, there's just one main zirconia supplier in the world. Of course, they're differently manipulated by the different companies. But there are other problems involved in terms of handling and so forth. So it's not as easy as that. It's strong. We know that the framework rarely fractures, but we're seeing an amount of complications which are just unacceptable. So if one asks today, what is the state of the art of all ceramic materials for implant dentistry, we must acknowledge we have problems to solve, all right? So we're going to concentrate here this lecture on the hierarchical testing, going from the least to the most complex geometries, going from crowns to fixed partial dentures, and lastly, on full arch reconstructions, on all different kinds of materials that we can think of for use in prosthodontics. And we're going to characterize these materials with a relevant fatigue testing method. And how relevant can it be? Well, we'll see if it simulates the failures that we observed clinically. And this was done a while ago. It was developed at the Department of Biomaterials and Biomimetics at NYU. And I'm not going over too much detail on it, but we use sliding fatigue testing and accelerated life testing method. But in essence, what does it do? We have an indenter that contacts a cusp incline, for example. It applies the load, it slides 0.3 to 0.5 millimeters, and then lifts off the sample without causing it any impact, just as it does in occlusion. And these are some of the failure modes that has been observed in the clinics compared to some that were produced in this laboratory. Okay, so this was published 5 years ago, and everything that we're describing from now on will have been performed using this testing methodology. So as we said, metal ceramics, yes, it is our gold standard, and when we first characterized it, you'll be seeing this graph several times. Just be concerned about the horizontal axis, which shows the fatigue strength of the materials. And here we are in molar crowns, okay? So we see that the fatigue strength of metal ceramics, it's over 1,000 newtons. And let us see where zirconia is in this scenario. It is performing significantly lower in terms of fatigue strength. And this was also published a few years ago. And when you see these contours, when they do not overlap, it means that they're significantly different, okay? Can we improve zirconia? We certainly can. And I'm not saying that this is the best framework design that we could use, but it is clear that we must change the framework design. This is just an empirical framework design. We're just bringing knowledge from metal ceramics to all ceramic world. And as you can see, what it has is just a lingual collar connecting to proximal struts, so it further improves the porcelain support. And do we really need porcelain support? Oh, yes, we do. If we don't tell the CAD/CAM machine, this is the default coping that we may have, regardless of material that we're milling. So it is an even thickness coping. We propose to modify it because if you see a cross-section of a porcelain fused to anything crown, we see that at the end, the technician, he'll do the porcelain layering for aesthetics and function. And at the end, we may end up with a huge discrepancy in porcelain thickness that we will never know, as you can see from these slides. You see, we are having an even thickness in the buccal, which is close to 1 millimeter, but we're having 2.1 in the lingual. So is this a good scenario? Not for porcelain, okay? So compared to an even thickness coping, can we further improve it? Yes, we can, but yet we're far away from metal ceramics, okay? So now, if the problem is porcelain chipping, let us completely remove the porcelain. We have materials out there that we can use it as a monolithic material. As you can see, lithium disilicate, Emax. So let us see what's the performance of Emax, for example, in a 2 millimeter occlusal thickness. Okay, we see that its fatigue strength, it's even higher than metal ceramic. That's great. But we do not always have that amount of occlusal clearance. Let's say that we have 1 millimeter. It still performs quite well. So from this graph, which pretty much has characterized most of the relevant materials that are out there for when we're using porcelain veneered reconstructions, we see that yes, we have materials that can perform as well as or even outperform the fatigue strength of metal ceramics. But now for implants, there are a few other things that I would like to invite you to reflect about them with me. Okay, so one of them is that composite crowns, they have been shown to be better able to absorb shock from occlusal forces than crowns made of metal ceramic. And this seems to have an impact in bone, an important one. So it has been shown that ceramic crowns transfers higher stresses to the abutment and bone implant interface than composite crowns. And now when we rank the materials, when materials have been ranked for shock absorption capacity, we see that composite and above all acrylic resin crowns are more able to absorb shock from occlusal forces than crowns made of zirconia, ceramic materials, or even gold alloy that we know that it does present some ductility. So another thing and a very important aspect that we cannot forget, and this directly applies to implant dentistry, is that a patient wearing an implant-supported prosthesis, he presents a substantial loss of proprioception, okay, and a reduced tactile sensitivity. And that ultimately results in a decreased masticatory muscle coordination and therefore an increase in susceptibility to occlusal overload. So that is why some patients wearing an implant-supported prosthesis, they may be more prone to producing failures on their own restorations than patients wearing a conventional tooth-supported prosthesis. So now if we look back at the guidelines for reconstructions back in the early days of osseointegration, there was probably a gap in the course of evolution of prosthodontics, especially for implant dentistry. So you're all familiar with this publication. It's a seminal publication from Brandemark, where he stated back then that although empirically, because we didn't know all this, that artificial teeth made of acrylic resin tended to compensate for the resilience of the PDL. All right? So maybe we should look back, and I'm not even suggesting that we should go back to use the same composites that were used in the 80s, but what I'm inviting you to is to have an open mind and to acknowledge all the advances that have been especially in the polymer chemistry engineering. So we have composites that are completely different from the ones back in the 80s. And for those of you who hate the word composite and cannot even think of it for any type of restoration of final or definite restoration, you'll be happy with this slide that Dr. Morgan just showed you. So according to the latest Code on Dental Procedures and Nomenclature from the ADA, they say that porcelain ceramic, they're defined as a pressed, fired, polished, or milled materials containing predominantly, okay, inorganic refractory compounds, and that including porcelains, glasses, ceramics, and glass ceramics. So note that the word predominantly changes everything here. So that means that you can have some amount of organic metrics and some ceramics embedding all it, and it will be called porcelain or ceramic. But controversies aside between material science definition of porcelain, ceramic, and the ADA code, let's go to what really matters to us, okay? The IECs, and what are the questions that the clinicians would like to have answered if they are to use, or if they are willing to use, composites for implant-supported reconstructions. One of the questions that we thought of is how good is the bond between the composites and titanium? It has to be a strong bond in order to withstand occlusal forces, especially in the molar region. Strength, that's an obvious question. And aesthetics, why aesthetics? Because composites stain, don't they? All right, so going to the very first question, I'm not going to spend much time over this, since as long as you sandblast an abutment and you apply any type of metal primer, you can have sufficiently high bond strength, and not only in the immediately, but in the long term, as we have shown a few years ago. So we're good with bond. Let's move on to our second question. So this was a funny study that we did a few years ago too, where we compared several composites used as IECs for molar crowns. We compared them to PFM, okay, to porcelain fused to metal. But back then, we only did single load to fracture testing. And as you can all see from these numbers, we have seen that all the composites presented a strength as high as porcelain fused to metal. And we have to acknowledge that a single load to fracture testing is not a meaningful type of methodology to show anything. It doesn't mean much, okay? But believe it or not, this was one of the most important data sets that we have ever collected. And I'll tell you why. From this study, where you see the loads to failure above 1,000 newtons, we have learned that if we were to test composite materials for fatigue in regular screwed systems, we knew that the abutment systems, their screws, or even the implants, they would actually fail even before the composite materials. So just to give you an example, half a dozen examples out of our over 20 publications on the topic, where we have investigated, for example, the effect of implant abutment connection designs, external hex, internal conical connections, or what is the effect or the difference between screwing or cementing a crown over an implant, differences between platform switching and matching platform implants, and the combination of all of these. In all of these studies during fatigue, we have observed that the implant components, they usually fail at loads below 400 newtons. Okay? So just to give you an example of one of the strongest connections, because they're all internally connected, here are the failure loads. They're all below 400 newtons. So can we test composites on them? We certainly cannot. So, and as we see, what are the relevant forces in the mouth? These are just examples of maximum voluntary bite forces, and we know that patients don't do that every day. But just to give you an idea, and let's go to bilateral because they're more relevant. In female, they're already above 400 newtons. In males, they can be over 1,000 newtons. Let's put it as a relevant average, 600 newtons, okay? So this slide may explain why dentists, perhaps they feel more confident when they splint adjacent molars, for example, in regular screwed systems, all right? Because in maximum voluntary biting forces, or even in functional forces, they could be able to fracture the screw or the abutments and so forth. So we've learned that materials such as composites should be tested under fatigue on simplified implant abutment connections. So we cannot have screws. We need a solid abutment, a monolithic abutment, just as you see, just as the locking taper, because the screw-retained components would fail before the composite materials. So this is the very first fatigue study that was performed by Dr. Suzuki from Tufts University. And back then, he evaluated just two composites that were commonly used, diamond crown and ceramage, and he showed that the fatigue strength for both of them, they were not significantly different, as you can see from the overlap between the contours, and they were in the average of 800 newtons. An interesting finding from that study was that when we had a failure, it was usually a small composite chip that by repolishing, we could return the crown to function, if that was a real crown in a patient. Or if it were a little larger, the chunk of composite, it could be repaired for function and be returned to function instead of crown being replaced. But now, one thing that we have always questioned, because sometimes we have to acknowledge that there's just a huge chunk of composite onto the abutments. And if we bring the knowledge from porcelain, we see that that would never be feasible that would never be applicable for any porcelain-based restoration. So the question is, do composites need support, or how much support do they need? And we have designed this study where we had 3 different abutment designs. One that we called large bays, where you had a 6.4 millimeter base, and the other ones, they're small bays with a 5.2 diameter, and we had a 4 millimeter cone in the center just for composite retention, and we also wanted to see if we reduced that to 2 millimeters, where you would end up. This is just a cross-section of the crowns, so you have an idea of the heresy that it is. If we think of this concept for a porcelain, of course we could never have this amount of porcelain unsupported, as you've seen previously. So that's the large base, a small base with a 4 millimeter cone in the center for composite retention, and the 2 millimeter. So our findings were that with a large base, that's its fatigue strength, it's close to 800 newtons, nothing new to what we have seen before. And compared to the small base with that tiny little post for composite retention, there is a significant decrease in strength, but yet, still, we're in the 600 Newton average. And how were the failure modes in that tiny cone in the center? It was usually a crown debond. We didn't have an actual failure. But then when we used the same cone height, okay, for composite retention, but in a reduced base, we had a fatigue strength similar to the large base. So answering the question, do they need support? Actually not. And this study was the basis for the development of the universal abutment that you've just seen in the presentation of Dr. Morgan. One of the things that we've been realizing, we do fructography in every single study, and is that while you're packing a material, let's say an indirect composite onto abutment, we always ended up inserting some voids during packing. And this is true for a technician who is hand layering a porcelain, will always find some defects, flaws, voids, bubbles, and so forth. And it is also true for pressed porcelain, as we have seen. So can we even improve the material's overall strength if we mill them from a CAD/CAM block, where we're having the material being more homogeneous? Well, let's see, we have investigated that, and we have compared the indirected composites that you've seen with a resin nanoceramic material. The brand name is Lava Ultimate from 3M, and of course with our gold standard, which is metal ceramic. And we have found that, yes, there is a difference. You can get a substantial increase in fatigue strength, and we have been realizing that this is true for other materials as well, when they're coming from CAD/CAM and we're using them as IECs. And interestingly, both of these materials, they're not significantly different in terms of fatigue strength from metal ceramics. So this clearly shows that, yes, we're on the safe side. So just as a clinical significance comment here, as we think of repair, these are some of the failure modes. So on the left-hand side, you see an indirect composite, or it could be a CAD/CAM block, failed, and on the right hand side, you see a metal ceramic failed. So clinically, which one would be easier to repair? Well, for an indirect composite, all you need is a hydrophobic adhesive and just pack some composite onto it. For a metal ceramic, what you need is metal primer on the exposed abutment, hydrofluoric acid etching, silane, plus the composite. And we're commonly saying that there's a huge advantage in composite repair, and we have no idea till not long ago what is the strength of a repaired composite. So this was an interesting study that we have recently done. And one of the things that when we think of a block for a CAD/CAM, we have technology that, yes, we can get an acceptable aesthetics, but the blocks themselves, they're monochromatic. So until the companies develop different shades within a block with different degrees of translucency, we're sort of limited in terms of aesthetics. Can we improve that somehow? Yes, we can. We could add a layer of direct or indirect composite onto an under-milled CAD/CAM block. Okay, so obvious questions. How strong is the bond between the CAD/CAM composite and a direct or an indirect composite? And obviously, what is the strength of a repaired crown? So in terms of bond strength, we have performed a microtensile bond strength testing, and we have found that the bond strengths, whether you're using Ceramage, an indirect composite material, or Filtex Supreme, the bond strengths, they're high enough to withstand occlusal forces. Now, moving on to the repair study, we've developed a method to standardize cusp removal and to replace it back with either a direct or indirect composite. In this case, the same composite that we used for bond strength testing, Ceramage and Filtex Supreme. So this is the inherent material. You have already seen this plot. And to our surprise, when we used a direct composite material, like Filtex Supreme, yes, there is a decrease in strength, but still, we're in the same average, or in the same average of fatigue strength of metal ceramics. But most surprisingly is that when you use an indirect composite material on the top of a CAD/CAM block, we go back to the same original strength of the inherent material. So there's no loss in strength. So is repairing composites a safe procedure? Yes, it is. And most interesting, this was really fun to see. The fracture that we have observed in fractography, it never occurred at the bonded interface. It was always cohesive within the composite. Okay, so then we answer the second question regarding strength. And going to the third question, which we're also not going to spend much time over this because you see from clinical examples several composites being used over 5 or 10 years. But just to show you some scientific study of composites that were aged and subjected to staining in coffee and wine. Okay, that's the most aggressive type of staining that could be in a composite. So these authors, they have found that staining is superficial, only 20 microns of the surface. So original composite color can be reestablished by polishing. This is nothing new to Bicon users, and who does IECs probably know that this is totally doable. So we're good with aesthetics too. And as Dr. Morgan said, this could even be called, yes, why not, ideal telescopic crown. Not only you do not use a cement, you do not need a cement, but the crown is still retrievable. So moving on to our second scenario, which is implant supported for fixed partial dentures. Let's take a look at the clinical outcomes and the literature that we have for the different materials. We will go straight for the strongest ones, which is zirconia. So this is a study which is a prospective cohort of 5 years. It's the same study that I showed for crowns, which showed a 42.8% of porcelain chipping in crowns. When it comes to bridges, they have found 62% of porcelain chipping in 5 years, okay? And another study where they have evaluated 2 different systems, zirconia systems, they have found 17 to 69% of porcelain chipping also in 5 years. That's pretty much the same scenario that we have seen for zirconia-supported crowns over implants. So this, for us, it definitely raises a red flag and calls us for alternative materials. And when we talk about fiber-reinforced composites, why? Well, because they present a unique high stiffness to weight and strength to weight ratios. What does it mean? It means that they're light, yet they can be very strong. And if we look around, fiber-reinforced composites, they are everywhere, all right? From the aerospace to aeronautical fields, and biomedical applications include artificial tendons, ligaments, intervertebral discs, hip stems, and so forth. So when used as an implant-supported restoration, it has been shown in finite element analysis that implant-supported fiber-reinforced composites, when compared to metal ceramics, they could eliminate the excessive stresses in the bone-implant interface and maintain normal physiological loading of the surrounding bone, and therefore minimizing the risk of peri-implant bone loss. The same scenario that we have seen for crowns. So this motivated us to further drop a few questions regarding the use of trinia. So one of them is how strong is the bond between trinia and adhesive cement, or most importantly, what is the adhesion like between trinia and ceramage? So in this case, we have evaluated also in microtensile testing the bond strength using just a hydrophobic resin, ceraresin bond from Shofu, in either sandblasted or no sandblasted trinia. And our findings were that bond strengths were high for either group, but there was a significantly higher bond strength when we sandblasted. Do we really need that much of strength? Of course we need, and we do recommend sandblasting, although the difference is not that much. If we see the numbers, it's 41 as opposed to 36 to a non-sandblasted trinia surface. But yes, it will be nice to sandblast them prior to composite veneering. To our second question regarding the performance of materials for implant-supported reconstructions used as fixed partial dentures, we have basically compared metal ceramics to pretty much everything that is out there. So, and that includes in every material, in every bridge that has a substructure, we have used a 12 square millimeter connection. So we have compared metal ceramic to trinia, also on a 12 square millimeters, veneered with composite, solid composite bridge, okay, no framework whatsoever, and zirconia veneered, also on a 12 square millimeters. And additionally to that, we have evaluated, and I know this sounds like heresy, but we did it, we have evaluated a trinia framework of a 3 square millimeter area connector. That means 3 millimeters height by 1 millimeter width, in addition to this group. So there are 5 groups here. And this is a cross-section, so you have an idea what it looked like, the solid composite, and that is the 12 square millimeters bridge. This is what everyone would conventionally use. We know that for all ceramic materials, that the minimum that we can use for zirconia is 9 square millimeters. And let's see how it all behaved. So in terms of probability of survival, trinia on a 12 square millimeter had the same probability of surviving that amount of cycles and loads as metal ceramics. And the same was true for the monolithic composite, okay? And the only difference here in terms of failure mode is that failures in the monolithic composite, they were catastrophic. There was no chance for repair. Zirconia had presented on the same framework design and area, presented a significantly lower probability of survival compared to metal ceramic and to trinia. And there was a drop, of course, in probability of survival when we went to that tiny connector in trinia, and it was similar to zirconia in the 12 square millimeters, although in higher numbers, okay, 79% as we see, as opposed to 55% for zirconia. So in terms of strength, if we put all of them in this chart, going from our gold standard, metal ceramics on a 12 square millimeters, we see that Trinia is not significantly different from them, nor is the monolithic composite. Not surprisingly, if we reduce the connector dimension to a 3 square millimeter, and that's a real worst case scenario, and that decrease in strength, significant decrease, only happens due to prosthesis flexing during loading. But when we put zirconia in the chart, it is not significantly different from Trinia in that tiny connector, and also not different in terms of strength from metal ceramic. But what is important to see here is that zirconia is down on the graph because it presents a low Weibull modulus, which indicates a wide variability in results and scattering data. So as conclusions, we see that the failure modes, they all allowed repair except for the monolithic composite bridge. And fractures were obviously larger in the 3 square millimeter due to prosthesis flexing when compared to Trinia 12 square millimeters. But even in that group, with that tiny connector, we did not find a single framework fracture, which was quite interesting, and it was a big surprise to us. And the probability of survival for any composite bridge in the 12 square millimeter dimension, they were not significantly different compared to metal ceramics, okay, except for zirconia, which was significantly lower. Now going to the very last scenario, which is full arch prosthesis. This is an example of a Trinia 4-on short. And how are we going to test that in the lab? Well, it's quite a challenge. And the best that we can do is to maybe divide that, split that in half, and test that as a cantilever, okay? So we designed, we thought it was crazy back then to have a 20 millimeter span cantilever, so that means 2 molars. And we found out just yesterday that was not maybe as crazy as we thought we could go. Yesterday we were testing an even longer span, which I'm not telling you today because we'll probably have all set of results in a couple months. But yes, a 20 millimeter span cantilever with 3 different framework designs. And let us see our findings. The only difference in the framework design here was the amount of composite that we had occlusal to the abutment. Okay, so we either had 1 millimeter, 2 millimeter, or 3 millimeters. And we applied the load in the most distal end of the cantilever. Of course, we needed to have some clearance, so to allow prosthesis flexing. And our finding was that there was such a huge amount of flexing before final failure that maybe from a clinical standpoint, that wouldn't be relevant because the prosthesis would be contacting the soft tissue prior to breakage. So clinically, what do we need? We need at least 2 millimeters on the top of the abutment. We haven't really evaluated anything between 1 and 2. We'll be doing that soon. But if you have 2 millimeters occlusal to the abutment, in that scenario of a 20 millimeter span cantilever, we can be on the safe side. So as relevant finding, if we want to improve the strength of a Trinia, when used as a 20 millimeter cantilever framework, we must provide at least 2 millimeter occlusal thickness for each coping, because that preserves the integrity of the fiber mesh continuity. So this is what we're looking for, and this is what we do want to avoid. Okay, we need fiber mesh continuity on the top of the abutments. So if we think of all the framework design principles that were, or that have been proposed for any porcelain veneered prosthesis, and we try to translate that to composites, they simply do not apply. Okay, so framework design principles for porcelain veneered reconstructions, such as connector dimensions or anatomical support for veneering, they're not relevant for Trinia prosthesis. So we can have the answers for these questions in terms of performance, and we must acknowledge that every decision that we make in the practice, they do have a role in the final longevity of the prosthesis. So most of these knowledge and most of this information is already out there in the literature. And we see that some types of treatment planning, such as, well, let us do a full arch zirconia on an external hex implant, on screw root form short implants. Do you think they're looking for trouble? I think so. So as a take-home message, when choosing a material for implant-supported prosthesis, let us consider how easy it is to fabricate, adjust, and repair. Always remembering that implant-supported reconstructions, they commonly demand more maintenance than tooth-supported ones. High reliability, what do I mean by that? High probability of survival, okay? Aesthetics and versatility, of course. And I do acknowledge that it's a massive amount of information, but, and much of it may sound like heresy, just as our group thought it was several years ago when we had started our own independent testing, but it is really clear to us now that we must have an open mind, all right? So as this German scientist who is known as the father of rocket science once said, one good test is worth 1,000 expert opinions. And patients, they do not benefit from random opinions. They're the ones who usually say, you're the doctor, go ahead and do whatever you think is best. So let us do our best. Thank you very much.